I wanted to preface my comments coming from a few of the questions and answers that we just heard, and from the good talk that we just heard. Hopefully that stimulated you, because I probably will put you all to sleep. And so hopefully you're peaking now, and then when you average out what I have, you'll still at least be upright. A couple quick things. One of the things that Mark said that I couldn't agree with more, that I think going forward, partly because of what we just heard, I think there's going to be a move, and this is maybe my optimism, that in the next 5 to... do you have the one that you had?
Yeah, but I have it on the
Oh, got it. I put it here, sorry. You don't have the one that I sent?
The one that was
just,
on,
yeah.
what's on it. Let me
Sorry.
see.
Yeah, I told you I'm not very technologically good. I gave her the wrong one. I apologize.
It's okay, let me see.
I sent one and then I found the spelling error. Doctor's English. But,
Okay.
you got it? Okay. So, I couldn't agree more that when we move forward with the expansion of the tests that exist, I think that there's going to be a lot of what I sometimes call strange bedfellows that we're going to find. That, as he quoted, there were, I think there are a lot of groups that are beginning to hear the call or recognize what was maybe less clear to them, more clear to others. I would like to think I'm in that latter group, but I think that we're going to expand the groups of people we can collaborate with if we allow ourselves to. And I'm at the University of Chicago, as was mentioned, and I definitely see that going forward. There are people who, in many ways, I disagree with, but in some ways I can find agreement, and that's a lot of what I do and what I work on. And so I think that's important for us to always keep in mind. I see policy and legislation, particularly in a representative democracy that we live in, as the art of addition, not subtraction. So I think it's important we continue to think in that way. And so I couldn't agree more with what Mark had said, that we have to always, be open to reframing this. And I think that this is an opportunity, because I think as the expansion of assessments are beyond what a lot of people think is bad, and I'm using scare quotes for a reason, because I don't, but a lot of people think of Down syndrome as bad, and we were talking a little bit beforehand. The way I interpret the data I'm going to present is sometimes very different than even the writers of the articles do in their conclusions, but I'm just talking about the data right now. And I think we have to keep that in mind. The second point was, again, there are other people who talk about this much better than I'm going to now, but I think it's crucial to keep in mind there are a bunch of data sets and then good stories, and they're both important in my life, that people who think of their children before they're born, so the question is looking for the perfect child, the perfect genetic before they're born, feel very differently after their child is born and when they're raising the child. There's a bunch of different ways it's been looked at in the ethics literature and other groups, and so I think that's important to keep in mind. If you ask parents about the perfect genetic code, if they have children, they say, well, my children have the perfect genetic code. I mean, my children, definitely. So you ask what parent thinks their child has the perfect genetic code, my children do. And I think a lot of parents think that way. And what I do is I take care of children with disabilities. That's my clinical practice. I work in neurodevelopmental disabilities or developmental behavioral pediatrics. And not all the families I take care of think that way, but many do, despite what others may think. And so I think it's important to keep in mind that even one's opinion about this may change with the experience of your own child or neighbors or things like that. And that's a little bit of what I'll touch on. So that in mind, I do this by page down or...
David,
yeah, there you go, that one, got it. Okay, so first of all, as was touched on, there right now is an ongoing and fast-paced expansion in the prenatal screening, both in terms of technology and in protocols. The technology, one example, the number of tests, the quad test now, which used to be the triple test, is considered, as was alluded to, the current standard, even though it's becoming outdated. And there is increasing sophistication within that. The technologies that are within these tests themselves are changing. So the groupings of the tests and the technologies of the tests are all changing, the sophistication is changing, and their use is changing. In addition, and in dynamic relationship to that, but important to separate out, or at least keep these things distinct, I think, is that the protocols or the use of these tests and the recommendations around these tests are changing, again, as was alluded. And I'd break those two as two different kinds of things. So there are increased suggestions or recommendations on how to use them in terms of expanding numbers, and there are increasing recommendations about use of what I would refer to sometimes as invasive testing. Ultrasound here may or may not be in that category. And I guess invasive / expensive is a little bit what I'm getting at there. Just to touch on it, because I think it is the current standard, the quad screen is what would be considered the current standard screening test, as was alluded to. It's not the cutting edge that was mentioned. And that includes 4 components, hence the name quad. The AFP, or alpha-fetoprotein, it's a protein that's produced by the fetus. The HCG, it's the human chorionic gonadotropin. I can't speak this morning. It's a hormone produced within the placenta. Estradiol is an estrogen produced by the fetus and the placenta, and inhibin A, which is the newest addition, produced by the placenta and the ovaries. This is what's currently being used. It's the same as that previous triple screen, which was the standard for a long time, except for the addition of that last. And the likelihood of identifying pregnancies at risk for Down syndrome is higher through the evaluation of this last, and so that's why they added it. Again, I'm not going to go through the details of this. I figured that would already be touched on and has been. And in general, what it's done is increased both its ability to detect and decrease the number that are detected falsely. However, as was again alluded to, I think this testing is likely to increase in the near future. Because there's an increase in not just sophistication, but now a changing of the way the tests are done in terms of the blood test. And the simple blood test for Down syndrome was the headlines. This is one of the papers that brought those headlines. There are ways of testing for Down syndrome now, as was alluded to, through analysis of the maternal RNA in maternal plasma. And in this study, trisomy 21 during the pregnancy was detected, in their term, non-invasively in 90% of cases and excluded in 96% of controls, which in the scientific literature, whether or not this is good enough, from my perspective, I'm not arguing, but in the scientific literature, this is considered a good standard. So I was asked to kind of look at, with that as a preface, kind of where are we now? And where are we now in terms of the use of these tests, and what does that mean? And I think that if there are take-home points before I put you to sleep, I'd make these. First of all, I would say that data sets are increasing, that in talking about this in this kind of way over the course of the last 5 to 10 years, the amount that is known, the studies that are done have increased and in their sophistication improved. I would say still, as has been alluded to, Europe is far ahead of the United States here in terms of collection of data. That's what I mean by ahead. Than the United States. That has always been the case. The United States has improved, which I'll touch on, and there's some better data. But as was alluded to and commented on, what is known is much greater in Europe in certain studies. I would also tell you that it's very important to remember now, especially in the United States. I think this is a big difference than other parts of the world and in Europe, but especially in the United States, there is not uniform, again, here the term that's sometimes used is uptake of screening. This is a language that's used in public health frequently, and it's not uniform in the United States for reasons that I'll touch on. And then therefore, because of that and because of other reasons on top of that, there's not uniform uptake of the intervention. Here, this intervention, this medical intervention, is the termination of the pregnancy. Intervention, I know, is a somewhat unusual term to use for that. I'm just using as neutral terms and for this kind of conversation as I can. And here, I would particularly highlight that subgroups matter, that averages across populations like the United States, as was mentioned, I think are somewhat irrelevant. They may be mathematically accurate, but to average my salary and Bill Gates' salary could be a mathematically accurate exercise and would mean nothing. And we can do a lot of things like that with math, and I think we shouldn't. I think that's a mistake. And so I think that we have to talk and think, because we'll do that more accurately and more effectively in terms of conversations, especially when we talk about the subgroups. And here, as I'll point out, I think race ethnicity is something that's talked about too little in this kind of conversation. I think it does matter. The data points that I'm going to suggest do mean that we have to keep this in mind. So getting into those data sets, here are some. There are others out there that I won't be talking to, and we can, in question and answer, talk about some of them if you like. Here are some that I think are helpful. These are, I hope this is presenting well, I tried to use black and white ones as much as possible for presentation. Here are I think, a graph that is helpfully simple. I'm a simple guy, so I think it's helpful. If you look on the bottom axis, actually I can use this so people on this. This can be seen if I use my, exactly, okay. So starting around 1985, running into 2000, this is the data that are in Paris of the total number of diagnoses prior to birth as percentage of the total. So this is a percentage that you're seeing. So 100 is the top there. And this is a percentage that are diagnosed prior to birth. And the two different lines here represent, the solid line are births of children of mothers who are less than 38. And the dotted line is mothers who are at 38 or above. And as you can see, over the course period of that we're talking about here, the around 20 years of the 80s into 2000, those two are getting closer to each other. That initially, most of the diagnoses prior to birth, and here's the key, because that's sort of what we're talking about in this conversation today. The total presented diagnosed prior to birth was very low in the less than 38. Because the protocols, not the technology, were not suggesting the use in that population. Whereas in the other population, you can see it's high and hasn't changed as dramatically. So the dramatic change in the past 20 years, as was alluded to, but I wanted to show you graphically, I think this is a dramatic graph, have changed dramatically in those women who are looking for a diagnosis under age 38. Okay. Are any questions about this?
Does this imply that the women who were diagnosed prior to birth went on to give birth?
No, this is just the diagnosis.
This is regardless of the outcome of the birth.
Correct. This is just diagnosis. Okay? Now, answering a bit of the question you're just alluding to, or at least implying, here are graphs that are talking about the prevalence of Down syndrome in Paris. And here prevalence is used in a way that's not usually used, but this is the way that the paper used it. This is per 10,000 total live births. So this is a ratio on the axis here. And the bottom axis, again, are years, basically the same time period, slightly different, but for our purposes today, I think about co-equivalent. And you can see that the dotted line, which doesn't reproduce well, but you can see the data points, I think, are the total prevalence. So that's the total number of pregnancies and births. And the bottom line are the total number of live births. Okay? So you can see that initially, the data points are fairly close together, and at the end of 20 years, they've separated dramatically. Okay? This is one way of representing what was talked about earlier in terms of the numbers that are known that don't go to birth. Okay? Now, one thing to keep in mind about these data sets that's important in all of our discussions and numbers is that there are not an insignificant number of pregnancies that are diagnosed with Down syndrome that end in miscarriage or end not in delivery that have nothing to do with elective termination. That's important to keep in mind. And all the numbers we talk about, we have to factor that in if we're going to be accurate. And I think it's important for us to be accurate if we're going to try to talk the truth. So prior to population-based studies in the United States, I would argue there's been a lot of misunderstanding and a lot of just on the basic number of how many children there are in the United States, how many births are existing, and this is one way to look at it. There are more than one ways, and I think they're all somewhat complicated. I chose this one. Hopefully it's helpful. So prior to population-based studies, so prior to looking at a whole group of people and the number of births and really drilling down, which is the standard in population-based health studies of any entity, from HIV to cholera to Down syndrome to anything else, this is considered fairly much the standard. And it hadn't been done in Down syndrome. So prior to that, based only on hospital report, which had been the standard for the longest time, the case ascertainment, or the number found, was underreported. That's now known. And this is up until the mid-90s, so this is a fairly recent kind of alteration. Now, when you think about it, there's been a lot of recommendations about Down syndrome and research money spent on Down syndrome, and we couldn't even get the number of children born right. I mean, that in itself, I think that disconnect tells you a lot about the scientific community's understanding of Down syndrome. You can't even know the number of the thing that you're studying accurately, and yet you have strong opinions about what to do about it. That shows you I don't think you've thought it through. And that's, I think, one of the big points I would make. So here, it was 8.4 per 10,000 terminations excluded and 8.8 terminations included. You'll notice that difference is not that great. So I would highlight that when you have inaccurate numbers, the numbers then you report and the differences are going to be even more inaccurate. With this population-based study that was done in Atlanta, not coincidentally where the CDC does a lot of population-based studies is based, it looked at the prevalence of Down syndrome both before and after the inclusion of prenatally diagnosed cases, so 1990, 93, and 94 to 99, these two different periods, and compared them in metropolitan Atlanta. It identified both infants who were born in spontaneous fetal deaths with Down syndrome, which was 387 as a total N, and pregnancies electively terminated, that was 139. It only here for these data recognized full trisomy 21. As an aside, there are other forms of Down syndrome, mosaic Down syndrome and translocation being the most common. There are probably a few minor variants. For numbers that we're talking about today, I don't think that they're tremendously important. I think they have other importance that we could talk about, but for this, I just wanted to point out what these data included. The point that I would say that's a take-home of this study, or at least one of the important points, is that when they started doing it this way, when they started not just looking at hospital reports in this way, but they actually drilled down and did a good study, the numbers significantly changed. Okay? And in the periods that we're looking at that are overlapping, you cannot argue that there's a major cultural shift or a major change in demographics or epidemiology. So this is simply because of the way they were collecting the data. I don't think anyone would disagree with that. So we went from 8, if you remember, 8.4 and 8.8 to 10.1 and 15.3, just by looking at your numbers differently, getting basically better data. Okay? So both of those numbers are from, if you work in this kind of world, significantly different. That's not rounding error, as it were. And so that's important to keep in mind, that whenever we're talking about numbers, if the numbers are inaccurate, they're probably not worth talking about. These differences are significant. And so really, if we're going to be talking about numbers, we've got to drill down and say, well, how is that obtained? And if it wasn't obtained healthy, I'm not even sure it's worth having an argument over, because I'm not sure it's helpful. And then you can really play with them. You can play with numbers that are good, but when you're playing with numbers that are bad, I'm not sure even what you're doing. A couple other things that I think are major take-home points for this American study. The prevalence of Down syndrome was 24.7 for women per 10,000 for women over 35 and 6.8 for women under 35. Again, that is to be expected. That shows you probably that their data set is good. That would be what you'd expect for all sorts of other things. Biologically, we know that the birth rate ought to go up, so this makes sense. But interestingly, a couple things they found out by doing this way, these weren't the points of the study, but in some ways there are interests that I found from the study, was that the proportion of cases that were electively terminated for women greater than 35 compared to women less than 35 was significantly different, with a risk ratio of 5, which again, just so you know if you're in this field, is a big difference. And so that's important to keep in mind. And it was significantly lower for African Americans, or in this study blacks, as it's framed, versus whites, among women who are 35 years of age. So again, the important take-home message here, I think, is that subpopulations matter. I don't know if that would reproduce in another urban center. whether these same data, and they don't make that claim, maybe in Boston or in Chicago or in other cities that would be the same, but it's important to notice that they found it. When you actually get good numbers, you can start to see these differences, and those differences matter. So, one thing that we can know, I think objectively and non-controversially, is that perinatal offices are an important source of cases for Down syndrome. And that's important because if you're going to put together policies or strategies of changing behavior or changing society, that has to be a target group. Up to a third of cases in women 35 years of age, that's where the action is, as it were. And that's important because if we target other places, delivery areas or traditionally places like that, we're going to miss at least a third, and maybe that's where a lot of the change is going. So I think that has implications. Also, a big implication, if we're putting together policies and strategies, we're going to have to target them carefully. If we're going to try to get the biggest bang for our buck, we may want to population base or strategize across different populations or race and ethnicities, and in many other things. Marketers know this. When McDonald's is selling its hamburgers, it does it differently in different populations, and that's why they're more effective. You don't have the same campaign everywhere. And so, I mean, there are commonalities, but it's important to keep in mind we can learn from other people who are effective with their campaigns in the same way. So, and even the writers of this I pulled this directly from, this is a quote from that article. We suggest that future reports on the prevalence of Down syndrome by race ethnicity take into account possible variations in the frequency of prenatal diagnosis or elective termination by race and ethnicity. So these are the actual population-based epidemiologists who are doing this study. They came on their own. This was not the point of their study, and I would argue this group is not one that's looking for this or even wanting necessarily to find it. I don't think they're against it. It's probably a mixed bag, but it's so obvious to them that that is one of their conclusions. And so I think if they're concluding that, those of us here who I think have a specific kind of mission and frame at least should take that into account also. So looking at overall numbers, having drilled down to that specificity, because I knew that looking at overall numbers is part of what we wanted to do, here are some data sets. Again, I'm presenting these, telling you ahead of time, as I've just leading up to now, that they have difficulties. So here are some numbers of expected live births in the United States from '89 to 2001. And let me tell you what these three graphs represent. The topmost graph are the kind of squares with a dotted line, are the births expected from mothers who are from 15 to 34, so young mothers. And this is a percentage in the change in the observed versus expected. So this is the percentage of births that you'd expect versus births that you got. Okay? And you'll notice that at the beginning of this, they're basically at 100. And if you recall the Paris data, that mirrors it, because you remember from the younger mothers in 1989, there weren't policies. There were technologies, but there were policies and protocols to do screening in that population. So if you're not doing screening, you're not going to find anything, so you're not going to change anything. And remember, this is expected live births, so this is taken out those births that end, or excuse me, those pregnancies that end in not in elective termination, but in miscarriage. So that's taking it out, so you can start here at 100%. If you didn't, you'd start at something lower than 100%. Okay? That's slightly complicated. If there's any questions, please, now's the time. Okay, so you can see it starts 100 and then has gone down in that period of time from to 50, well, just above 50%. Okay? If you look at the bottom dotted line, the triangles, that is the proportion of mothers, the other group that are, not all mothers, but 35 to 49. There are some that probably fall out of that, but for most intents and purposes, this is a group that's used. And so you can see in here, that's already starting lower at 60, but you'll notice that doesn't change much. So that's, I think, one of the more interesting findings that's talked about less, that I think is crucial. Over a period of time here, when this uptake that's gone on in terms of increase in technology, I've already mentioned, increased use in protocols, over that period of time, that group didn't change much. And as I told you in the the group in Atlanta, there's differences between older mothers and younger mothers that they find. We don't know why. The studies aren't designed to look at that, but we can observe this. And there is some change in variation, but you can notice there's a difference in the slope of these curves. And we don't know what the slopes will look like in the future, but these seem to suggest that there's kind of a floor effect, maybe. And just like Mark had said, this coincides with some of the data that he was mentioning earlier about the 60s are what some people suggest is what's going to be common in the United States. We don't know, but that's kind of what's in there. And then the total, the average between the two, basically is the solid line. So any question about this? So again, here, the change in the slopes of the graphs, or the difference in the slopes of the graphs, I think are what's most instructive.
What is their data set based on? Was that based on estimates based on expected maternal age and then the incident rate?
How they did their factor collaborate, I'd have to look at the paper, but I believe, yes, they took into account, I think, 3 things. Maternal age, which then changes your percentage of, miscarriages or not live birth overall. The Down syndrome and its change, its percentage, and I think they took into other risk. I think they knew other risk factors, but I'm not certain of that. I'd have to look to specifically. So one of the ways to then look at it is the birth prevalence. That is the number of children born in the United States with Down syndrome. So taking it the other direction. Starting, one direction is look at the number of pregnancies that go to delivery. One is say, well, just how many births are there in the United States? Because from a public policy perspective, and a little bit of the question about, healthcare and how we're paying for this, that's what a lot of legislators, other people care about. Well, just how many people are here? What are we talking about? And if you look at that, it hasn't changed as much as a lot of people 15 years ago, myself included, were worried it was going to change. We'll talk about why that's the case. But one of the policy perspective important things to make in mind that doesn't come out in these legislative discussions is, well, okay, we'll fight that fight with you because this is important. But there's not as many people with this, so we don't need to have that as a benefit, or we don't need to do anything about it because they're going away. We've read that in the paper. And you have to remind them, well, no, they're not. These numbers still exist. These children still exist. We still need to keep doing this. My clinic doesn't need to be shut down. Okay? And so that's important to keep in mind because a lot of people forget that. And in the medical center, I'll tell you, that's probably even more common than any place else. Because in the medical center, there's this sense of, oh, that's a problem we fixed. We're moving on to other more sexy, interesting things. And that's just not the case. Okay? And one of the reasons why in the medical center that's seen is because the care is done better and better, earlier and earlier, and so they're in the healthcare system in a negative way less, and so healthcare providers are less confronted by it, which is a good thing in a sense. But as I alluded to, the less contact you have, then the easier it is to forget. It's not decreased as much as predicted, and one of the reasons is because the maternal age across the United States, and there is variation regionally, but in general is significantly increased in the same time period that these protocols have been put into place. I think these are secular trends that are independent of each other. They just happen to overlap. But from 1989 to 2001, the live births to women greater than age 35 increased significantly from 8.4% to 13.6%. That's a significant change if you study these things. And one of the ways to look at it is the first births. So if you're looking at births, if it's the 6th of 7 that's older than that's age, which I happen to have been, that's one set of data. And in fact, Down syndrome, you could look at that in the past. So historically, Down syndrome trend frequently was the younger child of a large family. That was a common demographic when I started in this field. But now if you look at the first births, that increased significantly, almost a third. And if you look at first births to women over 40, as I was alluding to before, that's increased significantly. There's just a significantly larger number of women who are having children, especially their first children, later in life. And that's just happening in the United States. This has nothing to do specifically with why we're today, but that impacts this because the age at first birth or age at any pregnancy makes a difference into your rates. Okay? Historically in the United States, and this I think had political and legislative impacts, it was seen Down syndrome occurred in equal proportions across subgroups. Genetically, that should be the case, and it was the case. We know, in fact, this occurs in other primates. chimpanzees and other groups. So there would be no reason why there'd be racial subgroup differences. In some diseases there are. And so prenatal testing led to about a quarter of the reduction in lives with Down syndrome. And but I would argue now you're going to be starting to see, and again, we don't have the good data sets to see this very well. I mentioned the one, but I think we're going to see increasing differences across racial, ethnic, and regional groups and differences. And there's at least two reasons for that. One is that at least the data that we have, and these are not great data, so I'm not going to hang my hat on them, but they suggest there's significant differences in the percent of reduction in live births by race and ethnicity in a study in California in the early 90s, again, before a lot of this got up and running, so maybe things have changed. But there were significant differences in those who chose reduction, so-called, or termination by race ethnicity. And you can see here, and this is just the race ethnicity of the mother. And you can see significant differences with 4 to 5 fold difference if you compare the lowest versus highest group. In this group, the lowest group is Hispanics and the highest were white. And so this could be a major player going forward. It would be compounded if birth rates continue to be different across these groups, which they are. And also, in the world that I work in the south side of Chicago, this is a major factor. The United States, all the comment about healthcare reform, right now prenatal care is very different. The amount of prenatal care one gets varies a great deal by your race, ethnicity, socioeconomic status, and geographic region of the country. All those things play a role in it. This has been well studied by other groups. We don't need to do those studies. And that's going to make a difference. Because as I mentioned, it's not just the technology, as we alluded to in the first talk, but the actual use of that technology. And the use of that technology has to be done in prenatal care by definition. And if prenatal care is so very different, then therefore the use of this is going to be different. Okay, so the simple story is if you don't get prenatal care, which a lot of people in the United States right now don't, you can't have prenatal genetic counseling or prenatal genetic termination, or termination because of prenatal genetic conditions. You just didn't get prenatal care. So it's a moot point. In the United States, there's tremendous variation on that. On the south side of Chicago, there's tremendous variation on that. And that's one of the reasons, I would argue, maybe the reason why our data, when we can find them, are so radically different than Europe. Because in Europe, in general, they do have much more uniform prenatal care. Now, in general, I think uniform, as a pediatrician, I'm a card-carrying proponent of early prenatal care. Don't get me wrong. But we just have to keep in mind, the healthcare reform issues or the larger health policy questions, this will be factored into that. And so we have to be aware of that. That's one of the reasons why I mentioned we may have strange bedfellows. That this comes out in a way, when it gets played out in public policy, that's complicated. And there's going to be uncomfortable compromises and challenges. But for all sorts of reasons, we need to change this and make this uniform. I mean, I work not just with children with Down syndrome, and we need to change the rates of prenatal care and make them, in this way, more like Europe. In other ways, then, we need to do that in a way that's more family-centered and holistic, and I think more life-centered, but or just promotion of both women and children. So that's important to keep in mind. I wanted to have a good chance for a question and answer. So I will begin to start my conclusions here, and then hopefully we'll have a discussion of this. But I think that we can say, drilling down on the numbers, that there's an increasing percentage of children with Down syndrome from racial, ethnic minority groups that's impacting the epidemiology. I think we can say that. The amounts or the exact numbers I'm not comfortable in reporting, but I think that we can see this. And I think that differences in early prenatal care rates are increasingly important as prenatal screening and testing emerges. I think this is this gap can widen further. It's going to get worse rather than get better. Because again, if you have access to these tests, you're going to use them more. Ironically, in some ways, that will mean the people who have the most resources do the most damage to themselves and their families, if you see it that way. So again, the United States is a funny place to work. I also think that whenever we have these kind of discussions, if we too narrowly focus on individual decisions, we miss larger trends. Okay, as a clinician, individually taking care of patients, I know I'm prone to that. So when I go to these kind of data sets, it helps me reframe and think, okay, it's not just the individual discussions that are important. These overall secular policy and socioeconomic trends in some ways make a bigger difference than any individual discussions that we have. Because again, I can't have a discussion if we don't have the interaction. I won't have the interaction unless we have healthcare in a certain kind of way. So that's important to keep in mind. It also is important because if there are populations that have more children with Down syndrome, they could be, again, this is not my perspective, but I've seen this already somewhat, that when I've presented these data before, especially that, people will say, oh, the Hispanic families are doing it because they're Catholic and pro-life, as it were. And I pointed out to them, that may be the case. I don't know. The study wasn't designed for that. But it's clearly the case, because we have this, that they're not getting prenatal care. And it seems to me that's at least as likely a reason for this going on. Now, I don't see being a Catholic myself, as a stigmatizing condition. However, I don't think we should confuse the discussion that way. Okay? So it's important to keep that in mind in both sides. We can't oppositely say, oh, individuals are Hispanic, they're Catholic, therefore they're not doing this, because then when they get prenatal care, the numbers may change and may look the same. We can't count on that, as it were. And I'm not so sure that's even the right way to frame it. Okay? The second thing that I think is more subtle but maybe more important in the long haul is that if you are in one of the groups that has less contact, as I alluded to in the population or subculture of doctors, but this works also in race, ethnicity, or in geographic regions, if you're in a group that has a higher uptake and therefore less contact, it can be one of those things that can be self-fulfilling, and I think those Paris data seem to make me worry in that way. And in talking with my colleagues and in visiting my colleagues in France, I think that is a bit of the case now. That this whole idea that this is such a rare condition for a lot of people that they don't have personal experience with, that changes one's valence and understanding of these data and where we stand with these decisions. And therefore, I think we have to have policies that blunt those effects, that we mix people more and mix children more, because we know that makes an impact on their overall attitudes in their adult life. And I think that informs our policies. I mean, we have to take a multi-faceted approach. Approaches that address early parts of the pregnancy and the office, as I alluded to, but we also have policies that have to affect where children are schooled. I work a lot on that, in making sure that there's integration across many different groups.